which is brought to us by the World Diabetes Foundation. And it's going to be a panel talking about advancing digital health solutions for non-communicable diseases towards integrated health systems. Our moderator is a good friend of GDHF, Ms. Jacqueline Anyango Ogutu, heads the digital health solutions at the World Diabetes Foundation, and she's going to introduce our panelists. With her over 15 years of experience in healthcare, Jackie is specialized in leading multi-stakeholder projects, executing product strategies, developing and deploying digital health solutions. She's currently the head of the digital health solutions team at the World Diabetes Foundation, and she leads the implementation of digital transformation projects towards health systems strengthening in low and middle income countries. Her passion lies in human-centered design, innovations, and is focused on addressing challenges faced by people living with chronic illnesses, particularly in low-resource settings. Ladies and gentlemen, with a round of applause that burns all the calories you've eaten at lunch, put your hands together and help me welcome to the stage, Jackie.
Good afternoon. Good afternoon at the back. I didn't hear you. Fantastic. Thank you. Thank you, everyone, for joining this session. And also those who are joining online. We've been looking forward to this. And we have a great panel for you today with diverse voices from Ministry of Health in Malawi and Tanzania, as well as developing partners and tech implementing partners, which I will introduce shortly. But first, I just want to take a moment to say a big thank you to the World Bank for co-hosting this session, particularly Tony, who you'll get to meet, for helping design this session and working on it together. Thank you for that. Fantastic. Yeah. So, without much ado, why don't you help me welcome the panelists to the stage? First and foremost, our hosts from here in Kenya. Please help me welcome Dr. Gladwell Gadesha. She is the head of Division of Cancer and NCDs here in Kenya. Welcome, Dr. Gladwell. Secondly, let's welcome Chris Kulanga from Malawi. He works in the digital health team at the Ministry of Health in Malawi as Senior Product Manager. Welcome, Chris. From Medic Mobile, also known as Medic, please welcome Nekesa Were, who is the Director of Partnerships. Followed by Vivek Eluri. Vivek is from Resolve to Save Lives. He leads the implementation of digital health and partnerships and country implementation. So welcome, Vivek. And last but not least, please welcome Tony. Tony Muthe is Senior Health Specialist, and he leads the NCD and Mental Health Global Program. So please welcome Tony. All right, so here's what you're going to expect from us this afternoon. We'll have two segments. We'll start with country perspectives, where we'll hear from Dr. Gladwell and also from Chris on the implementation journey for NCD digital health. And then we will open up the conversation to the panelists. But we really hope that you can engage us during that time as well. So if you have questions or comments, we're going to try our best to have some time for you to do that as well. So before we jump into it all, and let me see if the slides will cooperate. Yes. Let me just remind us again and set the scene why we decided to focus on this. Why is it important for us to address NCDs? More than ever before, the world is experiencing a rapid rise in NCDs, posing a significant challenge in health systems, particularly in low and middle income countries. As you can see, today, approximately 3/4 of global deaths are due to non-communicable diseases. And the vast majority of premature deaths, and premature NCD deaths is actually in low and middle income countries. These numbers are stark, but they are also make clear what is at stake. It's the urgent action for us towards preventing illness, towards early diagnosis, and managing chronic conditions effectively across primary care settings. Despite the scale of the problems, as you can see, based on recent data, investment remains woefully inadequate. Only a tiny fraction of global health aid targets NCDs. And even though evidence shows us that up to 80% of many of the NCDs could be prevented, in fact, according to recent data, modest per-person investment in prevention and primary care services could actually save millions of lives. At the World Diabetes Foundation, we are committed to partnering with low and middle-income country governments, development partners, civil society, implementing partners to change the trajectory of NCDs, particularly diabetes and hypertension. At the moment, we have implemented projects in more than 120 countries in the last 23 years and currently running around 31 countries that are ongoing across Africa. We continue to invest also in digital health initiatives such as the Diabetes Compass that have been rolled out across multiple countries. And our unwavering belief is in the power of digital health solutions to increase reach, particularly in the most underserved communities, to improve efficiency in service delivery, and to ultimately improve health outcomes. So with us keeping this in mind, ladies and gentlemen, allow me to transition to our next segment, and this time we will get to hear from the countries. So please welcome Dr. Gladwell Gadesha, Head of Division at the Ministry of Health in Kenya.
Thank you, Jackie, for setting the stage, and good afternoon. So I'll take you through Kenya's transformative journey as we tried to enhance digital systems for NCD care. So I'll first start with the historical context. Most of the transformation happened after 2023, but before 2023, there were some things that were going on. In terms of legislation, we had the Data Protection Act that really tried to regulate how personal data was handled, processed, and shared. We also had a lot of manual systems, but we did pilot digital systems that were mainly disease-based. And one of them is what we call SPICE, that is an integrated EMR, so to say, for diabetes and hypertension. And this is what we have been improving through the years so that it is more responsive for our needs as a division and also the users who are the healthcare workers. So there's been a lot of learnings we've had from this system that started as a pilot. We also, in terms of disease management, most of it was vertical. A lot of even within the disease spectrums, there was separate days for managing patients with hypertension, a different venue for some of them even for managing diabetes, adding to the layer of complexities and why it makes it imperative that for NCDs we really needed to have a digital system. What did we gain from these pilots? It was really a proof of concept that it was doable, especially for NCDs at primary healthcare level, at lower levels, and especially at rural health setting, where you imagine the infrastructure was quite challenging. Come 2023, post-2023, a lot of legislation aided in the digital space, and one of them is the Digital Health Act that now provided for a unified, integrated national management system, and that also came about, we had the social health insurance. This is mainly on the financing side, but it also mandated that the automation of care, so that the quality of care can be improved and also that the claims can be managed, it also mandated that the process be automated. Hence, it was no longer also just a good thing to do for NCD data, but really a must because of the linkage to insurance. And then the last act that came into being was the Facility Improvement Fund, again also related to revenue generation, but most importantly, the plowing back of financing backed at the health facility, and in this way they could, for their own records digital management system, they could improve the way they were handling data so that they could generate more revenues. So all those pieces of legislation actually helped us improve NCD data and the health data ecosystem as a whole. What also happened, we have two systems currently. There's the ICHIS at community health level and also the Taifa Care at facility level. So I'll talk more about the ICHIS in subsequent slides. But for the Taifa Care, so the ministry decided that we have multiple EMRs, but we needed to have a few, just for a bit of sanity in the country and just for them to talk to each other. They prescribed two systems, that is the Tibabu and also the Kenya EMR. And remember, I'd mentioned about the spice that we've been improving over time. What did this say? What did this mean now that the ministry had prescribed two systems? It meant that we had to enhance what was already in those two systems, and we have made quite some milestones when it comes to Tibabu, because there's no need of reinventing the wheels, and really the specialization that comes into the digital systems and the care invariably, really there are lessons that we had learned over time, and this we said we had to enhance with the Tibabu Care, which is part of the Taifa Care, the national EMR systems. And then in terms of patient management, we started looking at integration more carefully. And one example I can give is the World Diabetes Foundation project that helped us integrate diabetes and hypertension at primary health care level. So at least with that integrated care, it meant also that the digital systems deployment at that level was a bit easier for the healthcare workers who are seeing the patients at that side. Again, we continued the gains from that. We continued learning a lot with the implementation of these two systems, especially when it came to now the enhancement of a nationally rolled out system. And from us at the division, it was very clear to us that we could never manage having a parallel NCD digital system. That is because of the huge resources that are needed, and we knew that piggy banking or riding on what was nationally being prescribed was the only way to go. So for us, when the ministry prescribed these two systems, it was an easy win for us. What are we looking to in the future? We hope that there will be better enforcement of the existing laws and also the interoperability. I mentioned that there are two systems. We really, at the end of the day, we really need to ensure that we get data from both sides. And then, as you all know, digitization is quite a process. We don't have all of the two systems in all our health facilities, but with time we hope that, so that we get the whole outlook of the country, 100% rollout in all the facilities. And then importantly, for NCD care being a bit complex, you're even dealing with patients with more than one disease. There is the issue of AI, which helps the clinicians in the era of decision support. So right now, the SPICE had some elements of AI, which are used as nudges to help the clinicians, but the potential has not been fully utilized, and we're hoping that this will be improved in future. So I'll skip that because I'll talk more. So I mentioned that there is a community health system and there is a facility. And in between there is a red block, as you can see. So at the moment, it's not talking to each other, the ICHIS community, the ICHIS and the facility-based. But what we've done is we've improved the two systems in parallel. Like, for example, you look at the community, the ICHIS, we have a module for diabetes, we have a module for hypertension, we have a module for history of cancer screening. But most importantly, it is not just tick the box as you go for the community health promoters. We do understand they have a multitude of tasks to do, and yet here we are telling them, for example, if you get a patient with diastolic pressure above 140, you have to refer. It's not very easy for them to remember such things. So into the ECHIS system, we've built red alerts, we've built nudges, we built thresholds so that they're able to know what to do when the community member has certain parameters. We also have included in the World Health Organization cardiovascular risk tool, each that the community health promoter is able to take in the various variables. Is a person smoking? How much was a BP measurement for that day? What was the blood glucose level for that day? And in the back end, it's able to calculate a CVD risk, and then it's able to profile the patient. So depending on the risk for that patient, the community health promoter is able to act accordingly in terms of referral instructions and even referral venue for the community member. And I should have mentioned, for Kenya, we have 107,000 community health promoters, and they've all been kitted with a blood pressure machine and a blood glucose machine, so they are able to measure this within their the household level where they visit. So there's that next level now, the facility, which as a stopgap measure, we have deployed link desks at the facility level, which are manned by community health promoters, just in a bid to ensure that we capture this data that is coming from the facility. There's a referral form called Ministry of Health Form 100, and the person manning the desk is able to see who has been referred within this week. Have they come? And if they've not come, they're able to relay that information to the community health promoters so that they're able to do a callback. So at the facility level, we have quite comprehensive digital health system for NCDs that starts with the history taking, the clinician notes, and it's also linked up with the various service points like radiology and laboratory. So at the end of it all, we also make the clinicians work a bit easier by including decision support systems, so they are able to act fast and in view of the heavy workload that we have. And in case a patient is supposed to come to the facility and they don't come, the system is able to pick up those who have a missed appointment, and this information is relayed back to the community health promoters at that level to remind the person to come back to the health facility. So in our modest way, with the funding from the World Diabetes Foundation, we've been able to train over 2,000 CHPs. This is a drop in the ocean, I know, because I'm talking about 107. And then so far, we've kitted health facilities with 350 gadgets. And for us, because of the infrastructure, and we are really aiming at the lower level facility, we kit them with tablets, which are able to work both online and offline. We've learned some great lessons as we go along. For example, despite the two systems being prescribed by the ministry, our counties are still operating other multiple EMRs. That adds another layer of complexities. Then there is service continuity risks in terms of both the system downtime and also some infrastructure challenges like poor network connectivity, and then limited optimization. This one is a culture, really, we want to change, where the health facilities have this new opportunity to collect a lot of data, use NCD data for decision making, but they are not optimizing that. We want the health facilities, the counties, the sub-counties, and eventually also us, and us we're already doing, to base the decision making on the data they come. What are some of the recommendations? We prioritize that interoperability, and then we strengthen community linkage facilities. So this is still manual based, and we are still losing a lot of patients or community members to follow up. And then invest in digital literacy. First, making the healthcare workers and community health promoters aware of the importance of that data they are collecting, that is eventually feedbacks to the type of care they offer the patients. Lastly, I think the three things we've learned with Kenya digitization of NCD care, that you need strong policies, you need a robust infrastructure, and then you need well-trained and motivated staff. This can be your stumbling block. Actually, if your staff don't have or realize the importance of the digitization of the NCD continuum of care pathway. And then we long for Kenya, where our Ministry of Health, where we have one unified national data for all, NCDs, and NCDs are multiple, so that we're able to use this data for policy making and decision making. What are our strategic asks? And you might ask me, who am I asking? I'm asking this to, first of all of you digital stakeholders here, and also specifically to the Digital Health Authority, that we really need to overcome the fragmentation that is still existing in our system, point of care, and then we ensure that there is seamless digital operability for us, moving from the community to the health facility. And of course, all this will require sustained funding and sustained collaboration. Thank you so much for your attention. It is my pleasure now to welcome Chris, who is representing the Ministry of Health of Malawi. Thank you.
Thank you so much, Dr. Gladio and Jackie. I hope you are still awake. If you're awake, can you just wave at me? Thank you. Yes, so many are awake. Thank you so much. So my name is Christopher Kulanga. I'm the Senior Products Manager for Digital Health Division, that is Ministry of Health in Malawi. I'm here to share our journey in terms of digital health for Malawi. As a matter of outline, we will talk about the Malawi digital health landscape. Then I'll introduce what we call the big shift, the MAHIS, and then we'll share a little bit about the status of the MAHIS, and then also discuss the complexities of the big vision implementation, the MAHIS itself. I'll take you back to 2019. That's the picture you're seeing there. Just to provide the context, Malawi's digital health landscape has been largely characterized by siloed, vertical, disease-specific programs or systems that were introduced as projects. And as you know, projects have timelines. In 2019, we did an assessment, and we discovered we had over 31 digital health systems that were managed as projects. Most of these are dead. So we do have a huge digital graveyard of systems that never made it. In 2025, there was the famous aid cut, the stop work order. And now every partner rushed to the ministry to say, this is your baby. We've been taking care of him or her, but he's yours. So please carry on. And we said, oh, okay. So every day it was meetings of handing over systems. And we were overwhelmed. And we said, okay, what does it take to raise this baby? And we realized some of these babies are in high school and others in very expensive colleges. We can't afford as government. We can't. And so we said, so thank you, you've been helping raising this child, but we don't understand what it takes to raise this one. So let's do a proper assessment. So we carried out an assessment just to understand what the landscape is looking like. What are the costs? Interestingly, we would have one meeting. You're discussing a particular system being handed over. You discuss the costs. In the next meeting, there'll be new costs coming. In the next meeting, another set of costs. And we realize, no, this is not happening. But let's just have a comprehensive assessment to understand what is there. Guess what we discovered? Over 60 systems. Of course, some of these are subsystems. So you have one main system, and this module, and they have different ways of implementation. And so this is the picture. And I guess this is also a picture in most other countries. We have siloed vertical systems that are being run by projects. And at the end of the day, they die. We can't continue like that. The obvious consequences of that, we don't realize the optimal outputs of the investments. So if you look back 10 years, 15 years of your digital health journey in a country, you realize there's so much investment that has gone in there. And when you start to look at what is it that we've gotten out of the investment, nothing much to show for it. So that's one consequence. And also you have expensive yet unsustainable digital health implementations, systems that you cannot sustain as government. And you have duplication of efforts within a particular sector. For example, supply chain, 5 systems. This one is only doing inventory, this one disposition, this one warehousing, this one logistics, this one. I mean, how do we manage all these? It's very difficult. So you're duplicating efforts. Now, we needed to move away from there. And this is what we're sharing now, the big shift. So first is to understand that in this current era, digital is not a support function anymore. It is a core function. Very, very important. Can you imagine a laboratory that is functioning on a manual system altogether, everything paper? It's very difficult. You have machines that have to be integrated with EMRs and other digital systems. So digital is not a support function, it is a core function. It is there to support the actual service delivery, the actual patient management, the actual treatment, the actual services that we're offering in the facility. That realization led to the policy commitment by the ministry to say we need to embrace digital, not just as another, component, as a support function, but as a pillar. So within our Health Sector Strategic Plan 3, which is running from 2020 to 2030, we have the digital health as a pillar number 6, and is a reform area number 8. What it means is that digital health has a special focus and attention within the government priority areas. So it means it's no longer just, a support function. So digital health has the space that medicines and supplies have. That's a very big realization. And then there were structure changes. With that, there was a digital health division that was established somewhere around 2019. So we need to have a particular team that is focused on how we introduce, how we manage and sustain digital health interventions. And that's where I am coming from. And then, you remember the background, we have too many systems, siloed, vertical. How do we move from that situation, which is unsustainable? So now we had to think of a government-owned and managed system. So that's the Malawi Healthcare Information System. So government endorsed that system, the Malawi Healthcare Information System. Colleagues in here, we have colleagues in here that are part of that particular development and implementation of that system. And this particular system is a collaborative effort in terms of development, implementation, different stakeholders. Government is there just to set the direction. The World Diabetes Foundation was one of the first stakeholders to support the MAHIS. So when they came in the scene, we would like to support NCDs, and digitally we have ABCD plans. We sat with them and say, okay, thank you so much. We have this idea. By then it was just an idea. Jackie can agree. It was just an idea, the MAHIS. And I was a bit skeptical, but we said, no. We're coming from here and we need to move together. They were the first believers of MAHIS, and they invested. And the first module that was deployed was the diabetes module within MAHIS. Now, just to briefly give you the conceptual perspective of MAHIS, we're looking at the healthcare system or healthcare sector at large. We have to say, okay, what is it that we need to digitalize? Because we just also can't say we need to digitalize and we don't know what we need to digitalize. So first of all, we have to establish what are the core services. So you have, for example, the inpatient services, the emergency services, the outpatient services, and the other services. So we said these have to be digitalized. It means that particular system that we're calling MAHIS has to take care of the issues or the workflows within these particular services. But we also realize that these are not the only services. We have got the logistics and the pharmacy and so on. So lab and many others, the community health. So we also had to bring this on board. So what you're seeing there in this conceptual model is basically what we had to come up with for us to define what system we want as one consolidated system owned and managed by government. So the different pieces there you see are the different services that are offered that we said, these we need to digitalize. And we also have to think of how are they going to interact, the different services in the digital space. So you see different arrows moving there, one from the community, going to the facility, others coming from the facility, feeding into the management information systems like GDHF, where you have aggregate data and so on and so forth, feeding to the supply chain and so on. But the point is we needed to first of all understand ourselves and map out what it is that we want to digitalize. And from there, think about the technology. Most of the times we rush to the technology and we develop very beautiful technologies. We deploy them and nobody uses them because they're not solving the problem. They're not addressing the workflows. They're not working together with what is practical. So the MAHIS development status, the big shift. So for now, MAHIS is still under development, and some modules have been rolled out. So it's an incrementally managed sort of process where we are developing modules for the different services, and we are rolling them out. So what I have there to the right is basically some of the services that we have digitalized that are in MAHIS. The maternal and newborn health program, the OPD, where the NCDs also fall in, the immunization program, the ATC. The ATC is the Adult Emergency and Trauma Center. The head of ATC is here, Dr. Fosco. He leads the ATC in one of the referral hospitals, Queen Elizabeth Central Hospital in Blantyre. These guys gave us so much pressure. We need the system. If you don't do it, we're going to do it. And eventually we had to do it, and it's running. So in an emergency department, very busy, they use the digital system 24 hours, every single day. If the system stops working at 10 p.m., you see a message popping up. It has stopped. And someone has to attend to it. Oh, 5 minutes, now it's back. So that's the kind of environment and reception that this system has. Efforts are now underway to connect the community piece of NCDs, which is in the integrated community health information system, with the facility piece, so that on the community side, NCD clients can be screened and then referred to the facility, and the information that's been collected at the community is already available at the facility for further management. There is just one screenshot of the Malawi Healthcare Information System, and there is just one of the pages, which is basically taking the vital signs. And as you can see, the MAHIS is built in a way that you move step by step, and as you're moving step by step, you're able to see what you've been able to do on the patient as the management of the patient is actually progressing. Now, has it been a smooth ride? Is it easy as a pie? No, there are complexities. And we want just to talk about those complexities of the big vision, of the big shift. So several complexities arise. Not that we have to let go, but we have to see how to resolve them. First is administrative. And in here, I think there is a missing piece, the governance. We need to be clear whose role is what. Who is to do what? What is the role of government at central level? What is the role of government at the district? What is the role of government? All the different stakeholders. What is the role of the different development partners and, implementing partners? So governance is a big piece. The complexity around that is that you're dealing with entities that are independent. They have their own administrative structures and systems and policies, but you're bringing them together to say, let's build this one big house that we all need. And someone says, for me, I cannot go by that because that's not my policy, and so on. But anyway, so there is administrative, we have funding issues that come in. We have some partners that still want to continue the old way. We have competing priorities against, from different programs. Some are technical challenges. You're bringing different development teams together. You fix this, and then it breaks whatever was working. So it's also one of the challenges. Code integration is a bit of a challenge also, and reusing old hardware is also a challenge. And lastly, there are challenges at operational level. Limited tech support in the health facilities, and also sometimes no dedicated budget support for the digital systems in areas where you are implementing. I thought that's what we wanted to share for now. Thank you. Asante sana.
Thank you very much, Chris and Dr. Gladwell. Really, really inspiring to see the journey you've been on. And also just the mindset, the agility that you've deployed in Kenya in looking at how you can integrate with existing ecosystem. And also yourselves, Chris, just the pragmatism and step-by-step approach of building in a modular way that you address, specific needs, but ensuring that, it's built within the entire ecosystem. So really, really congrats on that. So I want to bring the rest of the panel onto this conversation, and we'll come back to you, Dr. Gladwell and Chris. But maybe I'll start with you, Tony, right at the end. We've heard from the country's implementation, and I'd just like you to lift, a bit higher, more broadly around policies and, winning strategies for implementation. So what do you think what are the kind of strategies or approaches that really are needed to accelerate digital transformation to support integration of NCDs within the health systems?
Thank you very much, Jackie, and thanks to colleagues from Kenya and Malawi for really grounding us on what this looks like at the front line. So thank you so much for that. So I'll offer 3 quick, I call them shifts, that I think are quite helpful and strategic in terms of accelerating digital transformation for integrated care. One is, and particularly for primary health care and to help countries move towards UHC. So one is we need to really start viewing digital as a core health system infrastructure and a cross-cutting enabler for health systems as compared to a nice-to-do thing. We really have to sort of center digital as a core enabler and as part of the health system infrastructure. So what does this actually mean? This means explicitly putting things such as digital architectures, data standards, governance into national health strategies, UHC roadmaps, and PHC reforms. We can no longer separate the two. If you're going to achieve UHC, if you're going to have PHC reforms, digital has to be center and central of that as a critical infrastructure and also an enabler. Second, we need to design digital tools around the NCD care journey and population health management. And I will do a shameless plug of the primer that we just launched this morning that really tells us how do we do that practically. So for NCDs and mental health and more broadly chronic diseases, the value of digital comes from linking the full pathway, from early risk assessment, screening, diagnosis, longitudinal follow-up, and having timely referral, all the way from dispensaries or primary health care to tertiary levels, making sure that the diagnostics, the laboratory systems are all connected. I always say that, and maybe this is an unpopular opinion, often what happens is that we do these mass campaigns and we do amazing screenings, but then we just leave it at that. I think that, again, unpopular opinion, but I think there's some ethics issues around that. If you're going to screen someone and tell them they have hypertension, you really need to link them to the healthcare system. And often those are the key break points that we see in healthcare systems. The third point is that we need to put in place rules and incentives that make systems interoperable and actually used. We've heard a lot about the issues around interoperability, and so we need to actually think about what are some of the rules and incentives that will support us in that. So policy and regulation needs to enforce interoperability and data protection. This means clarifying roles for Ministry of Health, digital agencies, payers, regulators, and setting expectations on how data is being used, whether it's for clinical decision support or performance management. So to summarize, Jackie, embed digital in PHC and UHC strategies, organize it around the NCD and mental health care journey, so we really have to make it person-centered, and we need to back it with governance and financing that rewards its use and interoperability. Over to you.
Thanks, Tony. And a really great reminder that as we build digital systems, we have to have care at the center of it. Digital should enable that care, but it should not, replace it or compromise the care that people need to get. So thank you for that, yeah. So we have both Vivek from Resolve to Save Lives and also Nekesa from Medic. You've had extensive experience implementing digital solutions already. And maybe I'll start with you, Vivek. You've heard what Tony has said. From your own experience, what do you think has been some of the, the levers that have enabled you to successfully implement, and how are these systems to be integrated into the existing ecosystem? And maybe you could shed a light to Southeast Asia, because that's, the countries are not represented here, but I would love to hear from you about that.
Absolutely. Thank you, Jackie. First of all, I have the incredible fortune of spending extended periods of time on ground in between 5 to 8 countries every single year, right? And Resolve's philosophy, as you pointed out, Jackie, is about how do we deliver care to the people who need it the most, right? The only conduit for delivering that care is the frontline health workers, is the health workers in these facilities, right? So while we do talk about the extremely gnarly problem of building integrated health systems, we need to keep in mind how this helps out that healthcare worker deliver good treatment to the folks who need it, right? And oftentimes when you start looking at it from that lens, you start realizing that we don't need to solve the entire system. We can do it incrementally. We can break down the gnarly problem of fragmented systems. And oftentimes, low-tech, easy to implement solutions really work. A good example of that is literally Excel sheets, right? So there are n number of data entry platforms across the world. Most of them give a CSV or a Excel form of download. You put that in a macro and you get work lists for healthcare workers. And then, healthcare workers can take these work lists and address the problem of following up, of getting people back to care, right? So sometimes, while we don't lose our sight on the goal of having big, interoperable systems with longitudinal health records and health records traveling across, different levels of facilities, I think what is important and what has worked really is making sure that we don't leave the healthcare giver hanging because we want to achieve, a big systems change, right? Which oftentimes just means very simple solutions implemented. Southeast Asia, we work extensively across multiple countries in Southeast Asia. We work in Indonesia, and Indonesia has also been on this journey of building integrated systems. Indonesia is by far one of the most successful countries in implementing a standardized EHR while having multiple EHRs in their primary healthcare system. But they have standardized how the data entry happens within that EHR. And again, breaking the problem down of getting the data that is required for quality improvement for these programs. We did something that was fairly simple. We built something called hearts360.org, which is a website which just gives you a visualization of what an ideal dashboard for hypertension and diabetes care looks like. And what we saw was incredible. It was that individual districts which had these EHRs deployed, right, they were just picking that up and they were copying that dashboard and they were putting their own data on it. And then program managers and facility managers had data to manage the patients who were coming in, right? So to sum up, we can really think about systems change, and that's extremely important. But at the end of the day, what's going to deliver that care to the people is making sure that frontline health workers or folks in the facilities have the data that they need to interact with the patient in front of them and to deliver the care that's required to them. And digital solutions for those are not complicated.
Thank you, Vivek. Really great reminder about, again, it's not about complexity, it's about simple solutions with a clear aim of supporting those who need it, the healthcare workers. Nekesa, you at Medic, you've been exemplary in deploying the solutions to community health workers. If I'm not wrong, it's used by about 170,000 community health workers. Could you tell us a bit about that? But we're also interested to hear what have been if you could reflect on some of the pitfalls for deployment and how you've navigated that, and what kind of advice would you give for other countries who are implementing the same?
Yeah, thanks, Jackie, and we're an honor to be here on this esteemed panel. It's difficult to come last because I feel like a lot has been said, and now I'm struggling to offer something new. But yes, so MEDIC is the technical steward of the Community Health Toolkit, and we have been privileged to support deployments in several locations. We have an exemplar deployment in Kenya, the Electronic Community Health Information System, that's currently serving over 100,000 community health workers. We have deployments in Uganda, in Mali, in Nepal. And so we've been really privileged to earn the trust of our partners and be able to support them. They say misery loves company, so Chris, you might be happy to know that the challenges that you spoke about, we've seen as well, as we've worked across the continent and in Asia and other parts of the world as well. And this is why I come to the pitfalls. I think the major pitfall that we've seen is misalignment. Technology or digital tools have a habit of moving really fast, and sometimes outpacing the very system that's intended or is being built to support them. And so think about your policies, think about your budgets, think about the workforce. We're seeing that one of the things we need to be really careful to not do is outpace that system and work in collaboration with it. Yeah. And so what that means is avoiding the second pitfall, which is not designing with proximity. Right. And so you really need to be designing, bearing in mind your national strategies. You need to be designing with community health workers at the heart of what you're doing. You need to be building your tools based off of their lived experiences and not off of assumptions. And when you fail to acknowledge this pitfall, then what you find is that the kind of data that you're collecting is low quality data. You find that your tool is not being, it's not being adopted. And what happens as a result of that is that even when you receive real feedback, you're unable to work on it because the tool that you have built was not built for the system in which it is now working. And then the third pitfall that we've seen is not paying due consideration to the kind of the kind of capacity building the kind of change management that you need to do along with building your digital tool. So the digital tool has to be used by people, and I'm glad that we're talking about the importance of care now, because you need to acknowledge that you're going to need to think about how people are being supervised. You're going to have to think about the capacity building for people to use your tool. And so we really need to also be thinking about the investment in that, because at MEDIC we like to say that our tool is primarily built to deliver care. And when that care is delivered well, then you begin to collect the kind of data that you need to be collecting to support the system. So understanding that change management and its importance and the kind of investment you need to put in it is really critical. So what are we doing to avoid those pitfalls, or in cases where you've already fallen into that pit, how do we get ourselves out, is focusing on what I like to call radical localization. And so as a technical partner, as someone building a digital tool, you really want to be within the system, right? And so not just any system, you want to be within a system that has government in the driving seat. You want that system to have community workers at the center of it, and you want your implementing partners to be involved in the day-to-day. So you're working like a really well-oiled machine. And in Kenya, there's a really good example of that. It's the community health units for universal health coverage. A lot of those members in the room today, I'm happy to see them. It's over 20 different members, all part of this collective. Village Reach MEDIC obviously is a member. Living Goods, Luala, and several other partners. We also have funding partners. So J&J is a member of that collective. Elma Philanthropies is a member of that collective. And we work under the stewardship, under the leadership of the Ministry of Health. And it's a classic example of when organizations become selfless and focus on the whole and focus on the mission, which is how we're going to implement the community health strategy at, at a national level. Yeah.
I love that. You got me at selfless. Because indeed, it's the power of collaboration. It's coming together, and it's great to see that that's happening in Kenya and many of the other countries as well. And of course, we've also seen Resolve do that even through our Diabetes Campus project, and also now in Kenya, the collaboration with other partners like Medtronic as well to integrate. Yeah. So the clock is right before me, and I can see time ticking, but I'd really love to hear again from Dr. Gladwell and Chris. It's going to be a bit more rapid fire now, so really quick. Maybe I'll start with you, Chris. As you think about scale, because you showed us how you're deploying MAHIS in a modular approach, what do you think would be the greatest strategic action that needs to be taken to have the greatest impact? What is your focus now to ensure that you scale and don't fall into the pitfalls that Nekesa was talking about?
Thank you. Thank you so much. So I'll be quick. Firstly, being collaborative. This is not a one-man's journey. It is all stakeholders. So government, you set the direction, you set the vision, you coordinate, you provide the guidance, but bring everyone on board. The investments that everyone is bringing, let them come into that scale. Look at the strengths of each and every player, and then see how you can best leverage the strengths, how you can best leverage the skills, the resources that are there, so that you can run. You can run together. Someone is doing it here, and the other one is, so that's one thing. Number two, we should be practical. Ownership is not just on paper, not just in a document. Ownership has to be practical. You have to really own what you can sustain. Because if you claim to own something you cannot sustain, then you can't even scale. So you have to be practical, you have to own what you can scale, and you have to bring everyone on board. I would say those are the two main points for now in the interest of time. Thank you.
Fantastic. Thank you, Chris. And Dr. Gladwell, you had on your last slide, you had a big ask. If you're to prioritize, if we come back here 10 months from now, it's the next Digital Health Forum. What is the one thing that you think would be imperative for you, either from a policy perspective or more from an implementation?
Okay, thank you, Jackie. So I really can't give you one answer because we still have to work in tandem. We've done fairly well when it has come to the legislations, but operationalization of these legislations still needs an extra inroads in terms of making, for example, standards for interoperability. But in terms of operationalization, I think that is where more work is needed. And I'll echo my the panelists also, that we really need to make the governments be the face-fronting side of these digital ecosystems. And I'm saying that because, especially in a country where health is devolved, there is that progressive way you go down until the health facilities. But when you look at the county level, and the digital ecosystem or the transformation is being driven by partners, and the ministry takes a back road, there's a likelihood of just things working out for just a brief period, and then even a visited facility where we go and see the same tablets that were issued by our partners have been locked up, and they've been told that this is tablets for XY. So they're not seeing the benefits of this transformation to them, and it even goes as far as that technology transfers. So the technology should be transferred to government officials so that they're able to do their little troubleshooting that they're able to do. Then they are the ones on the ground, they can assist with any maintenance issues, so to say. So that phrase front-facing side of digital transformation from the government really needs to take the center stage. And lastly, the issue of the healthcare workers also realizing the importance of what the resulting data does for them. So this is still a culture that is not very well entrenched. They still see, healthcare workers still see that collection of data and analyzing as an additional work. But if you can see that all this is leading to better patient care, even better management of the little resources they have for themselves. I think this is one area we can operationalize and increase the utility of digital systems in general. Thank you.
Thanks a lot for really taking the challenge to summarize that. I know there's a lot that you put through in your ask. At the tail end here, I think it will be a disservice if we did not address the issue of sustainable financing, right? Do you agree with me? Should we take that one? Okay, Tony, I think this is for you. So if you think about, the current vulnerabilities that's being faced, what are your thoughts around sustainable financing, especially when we talk about scale? Everyone's thinking about scale. Please share your reflections with us.
Thank you, Jackie. That's quite a challenging question. So I think we need to take a step back and acknowledge a few things. For conditions that cause 75% of the disease burden and mortality in the world, NCDs and mental health conditions are woefully underinvested, and everyone has a role to play here. So governments are not funding NCDs and mental health at the level that they need to fund that. Development partners as well. So when you think about development assistance for health, you give us some numbers there between 0.8 to 2%. So I think we need to first acknowledge that financing for NCDs and mental health services is way, way below underwater. So we need to start there. And that means we need to think about, one, increasing the physical space for health. That's the first thing. The second thing is actually we need to look at where can we gain health financing efficiencies. So taking a step back, one, acknowledging the fact that for conditions that are causing the level of burden that we are seeing across the world, in all countries, across all regions, that we really have to think about how then do we actually channel more financing to these conditions. So really thinking about aligning population health needs with health financing. So we need to start there. And then second, we need to also understand that this is something that has to be country-led, which means that sustainable financing, at the core of sustainable financing, is domestic resource mobilization. Yes. Governments have to take lead when it comes to financing some of these services, right? Development partners and other sort of types of partners, the role that they can play or should play has to be catalytic to jumpstart reforms. But countries have to take the lead through domestic resource mobilization. So my central message to your question is when countries invest wisely in digital transformation, so building the right foundations, targeting the right levels of care, and supporting the right services, they make health financing more efficient, more pro-poor, which means more equitable, and more sustainable over time. So how that looks like quickly is financing the digital rails, or rather financing the digital rails reduces waste and fragmentation. Second, investing in digital transformation, particularly in primary healthcare, prevents costly downstream spending. Third, financing digital tools can enable better purchasing and accountability, which then means making every coin work harder. So that's sort of how I see it in terms of sustainable financing. There's a macro issue that I think we're not quite addressing, and we need to see digital investments and transformation as part of that solution to create efficiencies and to make us stretch that coin. Thanks.
Fantastic. Thank you for that. With 2 minutes to go, 2 minutes, 45 seconds, I actually want to hear from the audience, at least one question. Do we have a burning question? Whoever gets the microphone first. Who's going to help with that? Okay, we do have a gentleman right here with a question. Very quick, very sharp, and hopefully we can equally get a very quick response to it and make it in time.
My name is Julia from Cliniva. We are a healthcare provider and served tens of thousands of chronic patients here in Kenya. So a lot of what we heard today was about digitizing facilities, workflows, healthcare workers. But what we see from our data is that most impact on treating and preventing chronic disease actually comes from what happens outside the facility, in between visits, through day-to-day behavior change by the individual. And I think we all agree that AI in particular and digital health can play a huge role in that. So how are different governments think about that, if at all?
Thank you for that. Would anyone on the panel, Vivek, you want to take that one?
So the one thing that we're seeing is that AI is the buzzword everywhere, right? So governments across the world want some solutions in there. Something that we are experimenting with and we think would be successful, because a part of it has already been proven successful, is retention in care, which is patients coming back to the facility for getting their blood pressure checked again, for getting their blood sugar levels checked again, increases dramatically with constant messaging, which is low-cost SMSs going out saying that, hey, your due date was for a visit was such and you did not visit, do you plan to come back, right? So on the AI front, if we can make these more conversational and not, one-directional, make it more bi-directional, such as through a call, an AI assistant calling the patient and asking them to come back to care, or messaging, which is bi-directional, we think it'll have a big impact. And again, this is coming from the fact that in Bangladesh, where we work, we have a call center which calls up the people who haven't come back to care. And I forget the numbers, but it's over 60% of the patients who are called come back to care to get their medicines, right? And that's what keeps their blood sugar under control. That's what keeps their hypertension under control. But call centers are expensive, right? So can we use AI to have these calls automated? I think that's one area that we can explore.
Thank you so much, Vivek. And that was a great question, because indeed self-management support is critical. As we end the session now, I just want to invite you all. The conversation doesn't end here. Please come to us. We also have a station at the exhibitor booth, the World Diabetes Foundation. Please pass by. Let's keep the conversation going. We'd love to hear from you and the partners here and see how we can work together to advance digital health solutions for NCDs in an integrated way. So thank you very much for your time.
Thank you. Can we give them another round of applause?